You put out two reports. The first report, what was the main focus of that report? It was called CVS Caremark, an alarming prescription.
Yep, the first report that we published was really an investigation of the pharmacy benefit management industry, and in particular, an investigation into Caremark, because it is the second largest operator and it does have this unique marriage with a retailer. We were concerned about whether or not our plans, who had contracts with PBMs and especially Caremark, were actually getting their money's worth. One of the reasons that union funds or private insurance funds that we negotiate on behalf of our members retain the services of PBM is supposedly for cost control. But as you know and as I know, cost control in prescription drugs has not really been effective through the PBMs or through any other means. The idea is that by increasing the purchasing pool, by increasing the power of the PBM, they can negotiate lower prices for prescription drugs and save the patient and the plan money. What we found in this investigation was some evidence that seems to suggest that what Caremark had done instead was use the leverage of its massive customer base as a way to negotiate favorable deals for itself in terms of what prices it pays. And also to negotiate certain arrangements with drug companies to get things that they call rebates, where if they push a certain volume of a certain drug, they'll get extra financial incentives from Merck or Pfizer or Bayer or whatever the big company is, the pharmaceutical manufacturer. In addition to that, what CVS Caremark, what we found them doing is using the data that they have on their retail, on their pharmacy customers, and on the PBM customers that they serve to actually sell information that's collected from their customers to the drug manufacturers. They claim that that's stripped of personal identifying information, even if we think that that's not clear whether or not it is been properly protected. But regardless, they're using that information in a way that the customer most often doesn't realize, and in ways that we think is, if not illegal and immoral, that they're using this data to help, essentially market goods and services directly to patients and physicians in some cases, on behalf of pharmaceutical manufacturers. In some cases, doing direct mail to patients or to doctors, recommending that they use a certain drug or a certain product because they know that that patient is a diabetic. They're using this drug. Well, there's another drug on the list that this manufacturer is paying them to help market. So that's a real violation of trust. We think that it's an abuse of confidential patient information, and we think that it's a practice that needs to be investigated and to be regulated.
Yeah, and the PBM industry in general, because it's relatively new, is fairly unregulated.
It is probably the most unregulated segment of the healthcare industry. Very few people, even people who are knowledgeable about healthcare, really understand the model of how PBMs work, what they do, and how they've maintained profit margins that are really, really out of whack with what you would find in just about any other sector of business.
So your one section of your report talks about things that drugs do. You talked a little bit about the drug favoring, but it also talks about drug switching. What's that all about?
Well, that in sort of in line with the arrangements that they've negotiated with the pharmaceutical manufacturers, they have financial incentives to push certain drugs because those drugs are more profitable for them and for the drug manufacturer. And they've actually set up operations, in some cases call centers, where if a patient comes in with a prescription for this drug and there's a comparable drug that is more financially beneficial for the PBM and for the pharmaceutical manufacturer, they have, essentially claims adjusters who will call a physician and encourage them to switch someone's prescription from one drug to the next. There's also been some evidence brought out in litigation against the company in other cases and in other investigations that we cited in our report, where people's prescriptions have been switched without the consent of the patient or the physician, which really crosses a line in terms of laws that are provided to protect patients and to respect physicians' right to prescribe what they think is most medically beneficial, as opposed to what's most profitable for the PBM or the pharmaceutical manufacturer.
You also talk about in this report, you mentioned a little bit about the patient data, the way they utilize that for their own purposes, but then you talked about secrecy in their business practices. What did you find out in that sense.
Well,
What are you talking about there?
One of the things that the PBM enjoys its greatest advantage over the insurers that it contracts with, or over the patients or the physicians that it deals with, because it is such an unregulated sector of the healthcare industry, that there's very, very little in terms of requirements for disclosure and transparency in how they conduct their business, in what kinds of contracts and agreements that they enter into with the pharmaceutical industry, for example. If an insurer is supposed to serve the patient and the insurance plan is contracting the benefits, you would assume they'd have a fiduciary responsibility to serve the purpose that they claim to, in terms of trying to negotiate lower costs and to reduce the costs for the plans and for the patients. In fact, what they've done in some cases seems to be, just designed to maximize their own profits, even when when the patient or the plan are not necessarily getting the best deal. But because there's very few, there's very little ability to get access to the information about what they're doing and how they're doing it and what other interests they have, plans and patients find it difficult, if not impossible in some cases, to get information about whether or not they're getting the best price, whether or not their PBM is in bed with the pharmaceutical manufacturer that's pushing certain drugs onto them. So we've been supporting state legislation, and we will be supporting federal legislation to try and regulate this industry, so that they have to disclose those agreements. They have to disclose their contracts with drug manufacturers, so that there's restrictions on how patients' personal private information can be used when it comes to things like marketing, or when it comes to things like sharing that with a third party for any other reason. It's your patient information, it's your medical records. You should have the right to decide when and if and how that information is used. And we think federal law does have protections for that, but Caremark has been able to function in a little bit of a black hole in the legal world.
You talk in the report about actual fraud and service issues. What sorts of things did you uncover there?
Well, again, we've cited public sources. We've cited litigation and cases that have been brought against Caremark by state governments, by the federal government, by insurance plans that had contracts with them, where they did identify that they weren't getting the best deal, or that in some cases Caremark was engaged in practices like drug switching, which really did rise to the level of just outright fraud. There was one example where it was a public program, and the public program specified that a certain medication in a certain form would be reimbursed at a certain rate. That regulation didn't specify what an alternative form of the drug would be reimbursed at. So whenever somebody came in with an order for whatever it was, tablets, they would switch them onto capsules, and they would bill at a much higher rate for each prescription filled than they would have been allowed otherwise. And they got caught on that, and they've paid tens of millions of dollars in fines, and in some cases they're operating under consent orders, where they've had to enter into agreements with state governments and the federal government to agree not to continue those practices. But we suspect that there may be similar practices going on, especially in the private sector with private insurance funds, union health and benefit funds, things like that, where people just don't realize what's going on because they don't have access to the information.
Now, the second report that you put out, what was the focus of that report?
Well, in the process of researching the company over the course of the last 16 or 18 months, we actually went around and surveyed stores all over the country, about 1,400 stores in about 10 or 11 markets in the United States. And we went in and looked at everything from prices to products to the physical state of the stores to see what kind of condition they were in, to look at staffing, to look at quality issues, to look at affordability and access. And in the process of doing that rather intensive survey, we noticed some really, really striking patterns of discriminatory practices, of dumping expired products, of engaging in other kinds of practices that we think definitely takes advantage of communities and consumers, and in some cases may actually put the public's health and safety at risk in terms of selling bad products.
So the second report, maybe you can hold it up for people, is called Cure CVS. And we'll go through some of the sections of that. Before we get into the particulars, sort of what's the main takeaway from this report?
Well, the main takeaway of this report is that CVS has built its reputation on being a real quality organization who provides extraordinary value to consumers. I mean, that is most people's impression of CVS and when they think of retail drugstores, that they're good stores, that they have good quality, good service, and that they generally have low prices. But when we looked at those claims and we really, gathered a tremendous amount of data to take a more objective look at what was going on, we found that often CVS is not the lowest cost provider. provider on everything from prescription drugs in certain places on certain drugs to retail goods on a basket of typical retail goods compared to Walgreens or Rite Aid or other stores. We found that on average they're actually more expensive, so it's not a better value. And in addition, we found that problems like selling expired products, expired milk, expired eggs, expired baby formula, and expired over-the-counter medications, they had a much higher rate of selling bad goods than their competitors. So those are just a couple of examples of how we think that CVS is charging people top dollar for essential healthcare goods and services, and yet are providing poor quality services
and products.
It's really shameful.